Hi friends, so welcome to this INI-CET November 2024 Radiology Recall. Look at the first question. So they put an arrow mark here and they have asked you to identify what this particular blood vessel is in this MR angiogram. So what's this? This is an MR angiogram. What is it showing? It is showing us the intracranial vessels. Now let us look at a little bit of the anatomy of the carotid vessels. Now, the carotids, they arise from the aortic arch, not directly on the right side. On the right side, the first branch of the aortic arch is the brachiocephalic artery, which divides into the right subclavian artery and the right common carotid. Whereas the left common carotid arises directly from the aortic arch. Now, if you look at this MR angiogram taken at the level of the origin of the great vessels, if you see, this is the right common carotid artery and this is the left common carotid artery. Now, the common carotid arteries at the level of the mid and upper neck, they divide into two branches. One is the internal carotid artery, which continues intracranially, right? And we have the external carotid artery. So, the external carotid artery, right, predominantly continues extracranially. Now, if you look at the common carotid artery, as we have discussed, it divides into a smaller branch, which is the external carotid, and a larger branch, which is the internal carotid. The internal carotid artery is the main artery which is going to supply the brain. Now, let us focus on the external carotid artery. So, the external carotid artery, this is something related to the anatomy of the external carotid artery that we are going to discuss. So, the external carotid artery gives rise to a lot of branches, right? A few mnemonics are in play to help you remember the various branches of the external carotid artery. One of them is that some anatomists like to freak out potential medical students, right? So some anatomists like to freak out potential medical students. What are the branches of the external carotid artery in their sequence of origin? Let us quickly have a look. So what do we have? The first branch is the superior thyroid artery. Next is the ascending pharyngeal artery. Then we have the lingual artery. Then we have the facial artery, the occipital artery, the posterior auricular artery, right? Maxillary artery, a very important branch, and the terminal branch, right? What is this? This is the terminal branch of the external carotid artery. That is how the external carotid artery continues. Is what? It is the superficial temporal artery. Yes. So these are the branches of the external carotid artery. Now the internal carotid artery we have seen is going to be the main artery which supplies the brain. It is divided into various segments, rather 7 segments. So we have a cervical segment, we have a petrous, which is the second segment. The third is the lacerus segment. Then the fourth is the cavernous segment. The fifth is the clinoid segment. Then we have the sixth, which is the ophthalmic segment, and then we have the communicating segment. So these are the 7 segments of the internal carotid artery. So this is the Bowtiller classification of the various segments of the internal carotid artery. Now, right, if you look at this MR angiogram, right, though an MR angiogram is predominantly done, right, while doing an MRI brain to look at the intracranial vessels, let us look at them first. So this major arteries is what comprises the anterior circulation. So can you identify the arteries in the anterior circulation? Yes. So this is the internal carotid artery, correct? Now the internal carotid artery divides on each side, as you can see, into the anterior cerebral artery and the middle cerebral artery, correct? And then they have the M1, M2, M3, M4 segments, and this is the A1 segment of the anterior cerebral artery, and this is the A2 segment, right, beyond the intercommunicating artery, right? Then you also have the posterior circulation. Can you see that? What are those arteries? So these are the vertebral arteries on either sides. They arise from the subclavian arteries. The two vertebral arteries will fuse together to form the basilar artery, and the basilar artery is going to divide into the posterior cerebral arteries, right? So these are the vessels that have been asked previously in various exams, right, by using an image of MR angiography. But this time what they did, the twist in the tail was that they put an arrow over here and they asked you what vessel is this. Now what vessel is this? Is it inside the cranium or outside the cranium? It is almost close to the skin surface, though you can't see the cranium here because that has been digitally subtracted. So this is a predominated angiography image which is showing you only the blood vessels. So this blood vessel that they have marked is actually an extracranial artery. It is actually the terminal branch of the external carotid artery. So what is this artery here and what is this artery here? This is nothing but the terminal branch, right? The terminal branch of the external carotid, terminal branch of the external carotid artery. And what is the terminal branch of the external carotid artery? We just saw it. Yes, it is the superficial. Yes, it is the superficial temporal artery. Superficial temporal artery, right? So this, the answer to this question was a superficial temporal artery. Now before we go to that answer, let us quickly look at some potential questions that you could be asked going ahead on MR angiographies. So if this is a normal MR angiography, we have just seen this here. Now in a patient of acute stroke, they did an MR angio and they found this. Do you see something unusual? Let us carefully compare the right side and the left side. If you look at the right side, you can see the internal carotid artery very well. It is dividing into the right middle cerebral artery and the anterior cerebral artery. This is the A1 segment, right? And this is the A2 vertical segment of the anterior cerebral artery. You can see the vertebral arteries, right, fusing together to form the basilar's, which are giving rise to two posterior cerebrals. That is also normal. Now look carefully at the left side. You can see the left internal carotid artery, right? It looks normal till this point where it branches into the middle cerebral artery, but where is the anterior cerebral artery? So what you're seeing in this MR angiography is that the signal from the left anterior cerebral artery is not seen. Why is it not seen? It is because the left anterior cerebral artery was thrombosed, right? So there was a thrombus within the left anterior cerebral artery. This was a patient of stroke in which, right, there was an ACA territory infarct on diffusion weighted images, right? And when we did an MR angio, the left anterior cerebral artery, as you can see here, is not, the signal is not, visualized, and therefore we concluded that it was thrombosed. So this is what they could probably ask you next time in a case of acute stroke, right? This is the finding that we are able to see. It could be an MCA. So if you'll have to compare the branches of the right and the left MCA, if you see a paucity of blood vessels alongside any of those branches, right or left side, it could be an MCA, thrombosed middle cerebral artery next step, right? So this is something that you need to look for. Now look at this. Look at the normal MR angio and look at this image. This patient had presented with acute subarachnoid hemorrhage. And in a case of acute subarachnoid hemorrhage, we were trying to find out whether there's any underlying cause, right? So this is not a complete reconstructed angio image, but this is a post-contrast MR angio where you could see a part of the right internal carotid artery there, but on the left side, there is a outpouching coming from the internal carotid artery. So what is this outpouching? This is nothing but a left internal carotid artery aneurysm, right? So berry aneurysms, right, are known to be, one of the commonest causes of acute SAH. So ruptured berry aneurysm is going to give rise to aneurysmal SAH. So this was a berry aneurysm which was seen on MR angiography. Yes, now look at this very, very peculiar finding here. This was actually a child who was presenting with neurological deficits, right? Right, loss of consciousness, weakness, cranial nerve palsies. In a child, stroke-like symptoms are very rare, so you have to consider certain peculiar conditions. What do you see here? If you look at the MR angio very carefully, see the posterior circulation looks all right. So the vertebral arteries are good enough. The basilar artery is good. It is dividing into posterior cerebral arteries, right? But if you look at the left ICA till this point, it looks all right, but then you are not able to see the left ICA branching into the middle and the anterior cerebral artery, right? What is happening on the right is similar. You can see the right ICA, you can see it up to this point, but then you're no longer able to see the branching of the ICA into middle and anterior cerebral arteries. So what is happening here is that there is a chronic gradual narrowing, of the, of the bilateral internal carotid arteries, right? A peculiar condition affecting children, right? Can you sense what the diagnosis here? Anyone? Yes. So what condition in children? right, gives rise to a chronic gradual narrowing of the internal carotid artery. The child is presenting with neurological deficits. What is this condition? Anyone? Yes, this is a Moyamoya disease. Funny name, right? But the disease is not funny because it affects children. What is Moyamoya disease, right? It is chronic gradual narrowing of the internal carotid artery that affects children. But remember, it is not an acute thrombosis or an occlusion. It is chronic and it is gradual. So what does the body do? Because it is chronic ischemia, right? Gradual narrowing, the body gets a, tries to compensate for this narrowing. How? By creating multiple collaterals. And this tuft of blood vessels that you see here in between at the center is all the collateral arteries, right, which there are numerous hundreds and hundreds of collateral arteries which are trying to enter the brain from its base. They are trying to perfuse the brain, right, because the main artery supplying the brain, that is the internal carotid artery, is getting narrowed in a gradual way. So when you do an angiography, you see all these tufts of collateral channels, right? Where if you do an invasive angiogram, as you inject contrast, just imagine if the contrast is going to travel up from the internal carotid arteries, they will enter into these collaterals and all these collaterals will get so opacified. All of a sudden, what is this appearance called as? Yes, in Moyamoya, this appearance is called as, yes, puff of smoke appearance. Puff of smoke appearance, right, on an angiography image is suggestive of Moyamoya disease. So just compare the normal MR angio where you can very beautifully see the internal carotids dividing into the middle cerebral and the anterior cerebral. Here you're not able to see that because there's narrowing and there's a tuft of collaterals there, right there at the center. This is Moyamoya disease, right? So we come back to this vessel. We have seen the anatomy of the carotid vessels. We have seen their origins. We have seen their branching patterns. We have seen their segments, right? And then we realize that the artery that the examiner is pointing to is actually an extracranial artery. It is a branch of the external carotid artery. What is this artery? It is the superficial temporal artery. So that was the answer to this particular question. Yes. Now, for a change, this time they asked you a simple one-liner question, right? No long clinical stem here. They just ask you, what is the investigation of choice for ureteric calculi? Let me take you back to what we have discussed in the main stem marrow videos in the genitourinary tract, where we discussed this clinical clincher. See, so frequently asked in these exams. It is a favorite of your examiners. So, if they give you a clinical history, what clinical history would they give you? They give you a history of acute lumbar pain radiating from loin to the groin, accompanied by burning micturition, frequent micturition. So this clinical, history capsule should clinch the diagnosis of what? So what are you thinking of? This is acute renal colic, right? So similar MCQ maybe in the next exam. They won't ask you a simple one-liner. They'll give you a history and they'll ask you what is the suspected diagnosis. With this history, the suspected diagnosis is acute renal colic. Then they would ask you, in this patient, what is the first initial investigation that you would do? What is most commonly done in the hospitals today is an ultrasound, which is done more commonly than an X-ray KUB. An X-ray KUB is preferred only if an ultrasound is not available, right? Because not all calculi can be easily identified. Smaller calculi and certain specific calculi cannot be identified on X-rays. What are those calculi? We are going to see that. Remember that USG, why is USG the investigation of the initial investigation rather, is because USG is actually considered to the investigation of choice for detection of hydronephrosis. Remember, we have discussed a concept in the videos. What is that? USG. Remember, fluid is friend of ultrasound. So wherever in the body you want to detect fluid, minimal quantities of fluid, the investigation of choice is ultrasound. And what is hydronephrosis? Hydro means what? Hydro means fluid, right? Therefore, fluid is friend of ultrasound. Wherever in the body you want to detect fluid, the investigation of choice is going to be ultrasound, right? So investigation of choice for hydronephrosis, therefore, friends, remember, is ultrasound. But is ultrasound the investigation of choice for calculi, renal calculi, ureteric calculi? The answer is no. Why? Because air is the enemy of ultrasound, right? And where does air come into picture here? Because kidneys, ureters, they are retroperitoneal structures, and peritoneum contains what? It contains bowel loops, right? So there's a lot of air many times in the colonic loop, which is just overlying the ureter. And so what happens here is that if there is a tiny ureteric calculi and the ureter is passing in the retroperitoneum by bowel gases in the bowel loops anterior to it, right? A tiny ureteric calculus can get obscured on ultrasound. Sometimes really becomes a big challenge to trace the ureter, right? Especially in an obese patient with a gaseous abdomen. And therefore, now they could ask you, I told you, and they did ask you in this exam, what is the investigation of choice for acute renal calcolic or say a case of renal or ureteric calculi? It is a non-contrast CT scan. And this was the answer to the question in this exam. Of course, if you have to see a calculus, you need not give, you do not need contrast injection. So non-contrast CT is the investigation of choice for renal or ureteric calculi. Then maybe next time they'll ask you, is there an investigation which can tell you about the composition of the calculus? The answer is yes. There is an advancement of the CT technology. This is what is called as a dual energy CT scan. Dual energy CT scan, right, works in a particular way such that it will help you determine or know what is the underlying calculus composition. Can you tell me what is the most common renal or ureteric calculus? Yes, it is a calcium. Yes, it is a calcium oxalate calculus. Yes, so it is a calcium oxalate calculus. Calcium is very well seen on CT scan, and therefore the investigation of choice or best investigation is CT scan. Maybe the next time they ask you, suppose you do an X-ray, which of these calculus you will never see on an X-ray? So these are radiolucent calculi. Three such calculus compositions I want you to know. So the first radiolucent calculus is a uric acid calculi, which will not be seen on X-ray. Second are medicine composition calculi. Mostly these are indinavir, antiretroviral drug. So indinavir calculi, and it could also be pure matrix calculi, which are radiolucent. Maybe next time they ask you, suppose you do a CT scan and you don't see that ureteric calculus on CT scan, then what could be the composition of that particular calculus? It is seen on other modalities like ultrasound. It is not seen on CT scan. Why? What are those calculi? Remember, it is number 2 and 3 of radiolucent calculi. Uric acid calculi, though they cannot be seen on X-ray, they are picked up on CT scan. But indinavir calculi and pure matrix calculi, they will not be identified even on CT scan. So what all do you need to know as far as the investigations and limitations of various modalities as far as renal calculi or calculus imaging is concerned is what we have discussed here in a very, very high yield manner. Now let us look at few imaging patterns. Look at these 3 X-rays. The first and the second X-ray is showing you renal calculi. There are 2 calculi. The first patient in the 0-minute film here, and in the second image you are able to see those calculi. Can you see the graphics there? So this is how renal calculi could be identified. Look at the peculiarity of the calculus here. So these are renal calculi. Look at the peculiarity of the calculus in the third X-ray there. Look at the graphics. What is this calculus called as? Anyone? Yes, so this calculus is called as a Staghorn calculus. Why? Because it looks like the horn of a stag. So there are some peculiar features that I want you to know as far as Staghorn calculi is concerned. So urolithiasis, calculus disease is a favorite topic of your examiners. This time, right, they were lucky enough that a single one-liner MCQ was asked. Next time they'll ask you something which is more detailed, something which is more precise. That is why we are quickly going through this particular topics and quickly revising it once and for all. So Staghorn calculi, remember these are called as Struve-White calculi, or these are magnesium ammonium phosphate calculi, right? They are usually, it is like a cast of calculus material which is entirely filling up the pelvic elysial system, and that is the reason why they take typically the shape like that of the horn of a stag or a deer, and therefore it is called as a Staghorn calculus. They are usually associated with, right, urease producing microbes such as chronic proteus infection or Klebsiella infection or Pseudomonas infection, right? So this is what you need to know as far as Staghorn calculi are concerned. Now look at the CT scan image. You can see on the CT scan, you can see a calculus in the right renal pelvis there. It is causing obstruction, so dilatation of the pelvis. This is the right kidney. The left kidney seems normal. Look at this peculiar calculus within the urinary bladder on the CT scan image. It is taking a very pointed or spiculated shape. This looks like a jackstone. So this is what is called as a jackstone vesicle calculus. They are monohydrate calcium oxalate monohydrate calculi. They are very fragile. So if you put a cystoscope within the bladder, they can be fragmented and then those fragments can be retrieved out. A very specific sign is associated with ureteric calculi on CT scan. If you see this tiny focus of calculus there where the arrow is pointing, can you see a soft tissue rim around it? So that is the thickened edematous ureteric wall around that calculus, around the wall, around the impacted calculus within the ureter. This is what is called as a soft tissue rim sign of ureteric calculus. What happens is, why is this sign important is because in the pelvic region, many times there are phleboliths. What are phleboliths? Phlebo means vein, liths means stone-like or calcifications. So there could be some calcifications along the walls of the pelvic veins and they can be misinterpreted as ureteric calculi. So this soft tissue rim sign helps us distinguish between phleboliths and impacted ureteric calculus, because these phleboliths usually on a CT scan they show comet tail artifacts associated with them, whereas in an impacted ureteric calculus, because the calculus is impacted there, the ureteric wall around it becomes thick edematous, and therefore if you see a echogenic focus, a hyperdense focus and a soft tissue rim around it, then that soft tissue rim is the ureteric wall, and therefore this is a soft tissue rim sign of ureteric calculus. So that is why identifying this sign is important, because it helps us distinguish between phleboliths which show cometal artifacts and a ureteric calculi which show a soft tissue rim sign. Yes, so this is the soft tissue rim here. Can you see that? Now look at this image here. Here you can see that calculus here, and there is a, so this is the calculus here, and there is a soft tissue rim of the edematous ureteric wall around it. All right. Now, yes, hydronephrosis we have discussed. USG is the investigation of choice for detection of hydronephrosis, right? It is usually the first initial investigation done in an acute renal colic. So what do you see is that this is the renal cortex, this is the medulla, and if there is a renal calculus, which is a non-obstructive calculus, you're able to see a hyper echoic focus with a dense posterior shadow around it. We have discussed this in the USG interpretation protocol. Now, a few days later, this patient presented with severe acute renal colic. Why? Because this calculus went from the calyx into the lower ureter, and when we repeated this ultrasound, look at the left kidney here now. You can see the cortex, but in the region of the medulla, can you see the dilated calycis as well as the renal pelvis as well as the ureter? It is all filled with anechoic fluid. So this is the finding of hydronephrosis, right? And that is the how the renal calculus can, an impacted ureteric calculus can produce hydronephrosis. All right. So that is the spectrum of imaging, various appearances, various important factuals, various important specifics and concepts related to the imaging of urolithiasis that I wanted you to know. So we come back. Investigation of choice for ureteric calculi we have discussed is a non-contrast CT. We have had a detailed discussion here. Supposingly, next time they ask you, what do you do for imaging of GB calculi? Well, instead of directly going to the answer, let us quickly discuss. We have discussed the concepts related to urolithiasis imaging. Now, can you tell me what is the most common composition of a GB calculus? These are usually, yes, mixed calculi. And because they are mixed calculi, remember that they have poor calcium content, and because they have poor calcium content, right, many times it happens that you do a CT scan in a known case of GB calculi and you are simply unable to identify that particular calculus. Why is CT scan not able to identify it? Because of the poor calcium content within it. And therefore, if they ask you what is the investigation of choice for a GB calculus, yes, it cannot be CT scan because of the poor calcium content. Many times these calculi are not seen, and therefore investigation of choice for GB calculi, remember, is an ultrasound. Did you get the concept of it? Right. So for ureteric calculi, most common calculi are calcium oxalate calculi. So CT is the investigation of choice. This does not work for GB calculi because of poor calcium content, and therefore USG is the investigation of choice. Maybe they could ask you, what about CBD, common biliary duct calculi? So, right now, tracing the CBD in its entirety on USG is very difficult. This is specifically applicable to the terminal portion of CBD, where the CBD enters into the region of the close to the duodenum, right, where it is joined by the pancreatic duct, and then it opens at the ampulla. This part of the terminal CBD is very difficult to visualize occasionally on ultrasound, and therefore, right, the terminal CBD imaging being difficult on ultrasound. What if a calculus is stuck there? You'll see the dilatation of the biliary tree, but not the cause for it, and therefore, for CBD calculi, the investigation of choice is a magnetic resonance cholangio pancreaticography. The imaging investigation of choice is an MRCP, where such calculi will appear as filling defects. They will appear as filling defects within the hyperintense appearing MRI bile within the biliary tree. Right. So we have discussed urolithiasis imaging. We have quickly discussed a few concepts related to biliary imaging as well. Yes. Now we come to this question where we will reach the answer by excluding the options one by one. So let us look at the history first. A 60-year-old patient, so an elderly patient is what we know, came with inability to bear weight. Why? Following a trivial trauma. And the following finding was seen on PBH and thigh X-rays, right? She has a history of weight loss. Oh, that's a clue. Well, a few students said this was there in the history. A few students said it wasn't. If it was, it is the examiner trying to help you by giving you a clue to the underlying diagnosis. What is the most likely diagnosis? So what was the finding? The finding on the X-ray was destruction involving the region of the acetabulum. While the region of the acetabulum, right, of the pelvic bone was destroyed, most students agreed that the femoral head was actually intact. So it was not the joint which was involved, but it was the focal involvement and bony destruction involving the acetabular region. Another X-ray was given where there was the femur, a thigh X-ray was given, and there was a fracture involving the right femur, that is the mid shaft of the femur. Now remember, femur being a strong bone in the body, it takes a very, very high impact trauma to create such a transverse fracture of the femur. So if an elderly lady falls down, usually comes with fracture, neck of femur fracture. That is one of the weakest part. But here the shaft of the femur was fractured. Remember, it takes a very high impact trauma, very high degree of force to create a shaft of femur fracture, right? And therefore, that points to a possibility of whether it was a pathological fracture. What is a pathological fracture? Something was causing, a weakening of the underlying normal bone. And because the bone was weakened, it quickly got fractured. Now let us look at the various options. As I said, we are going to reach this answer by excluding the option. So eosinophilic granuloma or Langerhans cell histiocytosis. We have discussed the history clinchers of bone tumors, where we had discussed in the discussion that this condition usually affects children, the pediatric age group, and this was an elderly patient. I have pointed out the clues in the question. Can you see that? So therefore, eosinophilic granuloma usually is not going to be affecting the elderly patients. It usually involves the skull vault, right, or the vertebral bodies in children. Right here, none of that is involved. This is an elderly patient, cannot be eosinophilic granuloma. Can it be disseminated TB? Now, TB around the hip joint would be the hip joint tubercular arthritis. But in hip joint tubercular arthritis, we need to see the joint involvement predominantly, isn't it? So the joint needs to be destroyed, the articular surfaces need to be destroyed. There could be erosions, there could be altered density of the joint per se, right? Followed by ankylosis of the joint. But in this image in the exam, the femoral articular surface was completely normal. So the joint orientation was abnormal. That was predominantly because of the focal bony destruction of the acetabulum. Otherwise, the joint was not involved, and therefore the possibility of disseminated TB or TB joint, hip joint of the tuberculosis of the hip joint is also unlikely here. Now we are left with two options: brown tumor, which is a manifestation of what? Hyperparathyroidism, right? Focal, right? Excessive osteoclastic activity, resorbing the entire bone at that particular site. So it is a focal lesion. Yes. So brown tumor is possible. Metastasis is possible because of elderly patient. Axial skeleton, right? The hip joint or pelvic girdle is involved, right? So let us quickly try to identify the various clues here. Let us look at various clues. Age 60 years goes in favor of what? It goes in favor of metastasis. Whereas brown tumor, though it can occur at any age, usually can be seen in middle-aged patients. Metastasis, elderly age, metastasis is a more likely possibility. There is a history of weight loss. If this was in the option, again, this is a feature which is pointing towards some kind of a malignancy, right? Primary malignancy, right? Somewhere metastasizing to the bone. It is more in favor of metastasis. What was the overall bone density? If you look at the uh, radiographs here, the overall bone density otherwise looks normal. Normal. Look at the bones here, the overall bone density otherwise looks normal, and this is a point more in feature of metastasis. Why? Because brown tumor is a feature of what we discussed. It is a feature of hyperparathyroidism. So there is a tumor which is secreting excess of parathormone. What is the feature? What is the role of parathormone? The role of parathormone is to increase the serum calcium by mobilizing it from where? From the bones. And therefore, in hyperparathyroidism, there is excessive osteoclastic mediated bone resorption, right? Because the parathormone constantly going and activating them. So, in hyperparathyroidism, right, it is going to be decreased. There is going to be a decrease in the overall bone density, right? And at a particular site, the osteoclast will resorb the entire bone altogether. That is what looks like a tumor on gross histopathology. If we take a gross cut section at that site, because it is rich with mineral laden osteoclast cells, it actually appears brown in color. That is what is called as a brown tumor. So if the overall bone density was normal, it is again more in favor of metastasis, because metastasis is going to be a focally destructive lesion within the bone. Any other, because this was a long stem clinical question, right? A few students have said that there's no blood related finding or no other biochemical pathology finding which was given. Had they told you that there is an increase in alkaline phosphatase levels, that would again have gone in favor of hyperparathyroidism or brown tumors, but that was no such detail which was given, and therefore this does not point to brown tumor. If it doesn't point to brown tumor, it automatically points to the answer of exclusion in this particular case, and therefore metastasis. Now remember friends, all this discussion that we have had, everything of it would change, right, if tomorrow we realize that there was some new set of information available in that particular question. So as of today that I'm recording this particular video for you, right, this is the best available information in this question. This is the set of information where we saw that there was an elderly patient, right, who came with an inability to bear weight following a trivial trauma, no significant trauma, no high impact trauma. Overall bone density was normal, no pathology or biochemical findings were given, right? And we saw a finding, there was a focal destruction of the acetabulum and a fractured shaft of femur, because it was a pathological fracture at the site of a metastatic lesion. And hence, right, the answer of exclusion, we have excluded eosinophilic granuloma, pediatric age group, we have excluded tuberculosis involvement of the hip joint because the joint was normal, otherwise the femoral articular surface was normal. We have excluded brown tumor, overall bone density was normal, elderly age, right? There was no underlying pathologic finding or biochemical finding which is given, and hence the answer of exclusion here is going to be metastasis. So in the available set of information with the available images here, this is the best possible answer. How have we got there? We have got there by excluding the rest of the options, right? Now let us look at this particular question again. This was a chest x-ray based, image based question. So a 47-year-old diabetic patient came with fever, malaise and productive cough. So looks like a lower respiratory tract infection, right? And which of the following is an incorrect statement? We have said a lower respiratory tract infection, but what is the finding on the given chest x-ray image? Let us look at the chest x-ray image before we go to the options. What do you see on the chest x-ray image? Can you see these areas of haziness there? So this is definitely a patch of consolidation, a broad patch of consolidation involving the right paracardiac area, maybe the right middle lobe there. Also, there is again a big patch of consolidation in the left paracardiac area, probably involving the lingular segment there. So what do we see on this X-ray is that we are able to see large areas of consolidation. Now, there are two sets of thoughts as far as this question is concerned, right? Some students say that the options were related to the finding on the chest X-ray, whereas most students say that the options were related to the finding of consolidation and the various underlying etiologies of consolidation. So let us follow this thought and see what the options were. Let us go in a reverse manner here. Let us first look at the last option. So pneumonia, it was consolidation on the X-ray. So they said about, so they put an option about aspiration pneumonia. So aspiration pneumonia, they said, is most common in the posterior segments of the upper lobes and the superior segment of the lower lobes. This is correct. So the question was asking you to identify the incorrect statement. But see, aspiration pneumonia, when a patient is, say, an alcoholic patient, is altered sensorium, lying down, something gets aspirated from the esophagus, or the patient vomits, goes directly into the trachea, it would go to the most dependent part as the bronchus goes, right? The most dependent portions where this aspirate would reach is indeed in the posterior segment of the upper lobes and the superior segments of the lower lobes. So this is a correct statement. Hilar, let us look at the next option. Hilar lymphadenopathy with lung infiltrates are seen in malignancy. Well, malignancy on chest X-ray presents with very non-specific findings. Most common finding is that of a mass within the lungs with a lymph nodal mass, right, at the hilum, right. It could present with a corona radiata kind of an appearance, right, alongside the margins of the mass where the mass is infiltrating into the lungs. If the phrenic nerve gets involved, right, at the hilum, the ipsilateral hemidiaphragm is usually elevated. But occasionally, remember, especially in cases of adenocarcinomas, as well as in certain cases such as lymphomas, right, you can in fact see lung infiltrates or consolidation, or specifically in a low grade cancer which is called bronchiolo alveolar cancer, right, we can in fact see consolidation like haziness or lung infiltrates in the lungs along with lymphadenopathy. So this also seems like it is correct in some cases. What cases? Adenocarcinomas, lymphomas, bronchiolo-alveolar carcinomas. Interstitial infiltrates are seen in mycoplasma pneumonia. What is mycoplasma pneumonia? It is atypical pneumonia. Why is it atypical? Do you know? Because the underlying causative agent is atypical. It is not Streptococcus pneumonia, it is mycoplasma. Why is it atypical? Another reason, the clinical findings are atypical, right? It doesn't present with typical signs of a fever, productive cough. It presents with more constitutional symptoms like myalgia, headache, right? Why is it atypical? If you ask again, hat trick is that the imaging findings are also atypical. It does not present with typical lobar consolidation. It presents with interstitial infiltrates, reticular pattern, reticulonodular pattern. So mycoplasma pneumonia is atypical because the causative agent is atypical, right? The clinical findings are atypical. The imaging findings are also atypical. What are those? There are interstitial infiltrates. So this option, in fact, is also correct. Let us look at the first option now. Patchy infiltrates are seen in pyogenic pneumonia. Now, see, pyogenic pneumonia, usually community acquired pneumonia, the most common agent is Streptococcus pneumonia, right? So that is pneumococcus. It usually presents with what? What is the most common imaging finding as we saw in the X-ray? It is lobar consolidation. In very rarely it presents with patchy opacities, maybe in bronchopneumonia, maybe in pneumonias like Legionella, but these are very rare conditions. And therefore, remember, the most common imaging pattern in pyogenic pneumonia, community acquired pneumonia, is usually lobar consolidations, where an right, entire lobe or most of that lobe is involved in consolidation. It does not result in patchy infiltrates within the lungs, and therefore in the available options I feel this option A, patchy infiltrates in pyogenic pneumonia, doesn't fit together well. It is a very, very rare presentation like this or imaging finding like this. And therefore, if they ask me what is the incorrect statement related to consolidation within the lungs or infiltrates within the lungs, I feel that it is patchy infiltrates seen in pyogenic pneumonia. I just cannot justify it, right? It just doesn't fit right. This is not the imaging finding in pyogenic pneumonia, community acquired pneumonia, and therefore this seems to be the answer to this particular question. Yes. Now, friends, there are many more questions. There was a Zenker's diverticulum. There was a question related to low adenosine deaminase levels, right, which were asked. These questions will be discussed in the other subjects as well. We have just stuck to a few questions so that we have minimum overlap, so that time, the most important resource that you have right now, can be efficiently used. People say that you have to follow a steep path to success, right? I don't really feel that the way to success is like a straight line or a straight path. There are multiple ups and downs. So it is not a path to success. I feel that it is always a curve to success. Obviously, if you're watching this video right now, right, either you did not appear for the INI-CET exam and you're preparing for the upcoming exam, or if you did appear for this exam and probably you did not do very well, but don't get disheartened. Believe me, even if you feel that you are right here at the lowest ebb of the curve, I want you to realize that this is where things would start turning around for you. Remember that life and your exam preparation right now is full of ups and downs. There will be days where you'll do well in your test. There are days that you'll do much bad than what you expected to do in your grand tests. But that is the point of giving these tests, right? Just imagine if you get even a little bit better with each and every test and each and every video that you watch towards the end, as you go approach the exam date, with so much of effort that you are putting in, as a team we are putting in, I'm sure you'll be in a much better position to crack that particular exam. Believe me, the path to success is never a straight line. It's always a curve. But the most important thing is to believe in yourself. Remember, this curve is trying to tell you that it usually gets much worse first before it starts getting better, better. And what comes after better? What comes after better, better, better is what is the best possible outcome for you. Today is not your judgment day. This exam was not what was supposed to judge you, right? The exam, that is the upcoming exam that you're targeting for, is going to be the best possible outcome for you. Have this self belief in yourself, right? We are here with you to make sure that this dream of yours comes true. This was a small effort in that direction. I hope these videos, you find them valuable and they help you immensely in your preparation to this exam. Thank you very much. All the best.